Council, particularly Honorable President Dr. Arpita Chaudhary Madam and Honorable Secretary Dr. Manish Balwani Sir, for providing us this platform to connect and interact with transplant physicians and pathologists. It's our privilege to have Honorable President Dr. Arpita Chaudhary Madam, ISOT President, and renowned nepropathologist Dr. Anila Abram Madam as panelists. Joining me in moderating today's session is Dr. Jigar Shrimali Sir, who is Executive Council Member and Program in charge of ISOT CPC webinar series. Today, we will dwell into an engaging discussion on chronic active antibody-mediated rejection versus glomerulonephritis recurrence. Our case presenter is Dr. Aniruddha Datta, a budding nephrologist from the esteemed IPGMER, Kolkata. Let's begin. Over to you, Dr. Aniruddha Datta, sir. Thank you.
Thank you, Radhika, for your kind introduction. I think the program may be launched.
Thank you, ma'am.
Good evening, respected teachers, faculties. A patient. Now, to the beginning, our patient is a 32-year-old male who was diagnosed with chronic kidney disease stage 5, whose etiology was probably chronic glomerulonephritis. It was never proven. He did not have any family history of any kind of renal disease, and after a hemodialysis vintage of around 1 year, he underwent a ABO-compatible living renal allograft transplantation, the donor being his father, and as per institutional protocol, he received basiliximab and methylprednisolone as his induction therapy. His immediate graft function was very good. He was discharged on post-operative day 13 with standard triple immunosuppression, and his discharge serum creatinine was around 1. And after that, he had a completely uneventful 3 years in which his serum creatinine stayed in the baseline of around 0.94 to around 1.2. And after this period, in early of 2021, actually he developed some amount of proteinuria along with some edema. His proteinuria, when quantified, was found to be around 3.5 grams in 24 hours. And due to this, he was advised to undergo a renal allograft biopsy. Now, if we look at these biopsy specimens, the hematoxylin eosin stained and the PAS stained samples show actually there are prominent double contouring and thickening of the glomerular basement membrane, as well as some amount of mesangial matrix expansion. In the JMS stain, we can very well identify the double contouring of the glomerular basement membrane. However, no evidence of any kind of proliferative activities like glomerulitis or peritubular capillaritis was seen in this specimen. During this biopsy, his blood workup showed normal hemoglobin platelets, preserved albumin. His urine showed nephrotic range proteinuria without any kind of active sediments. His complement levels were normal. Full blood T0 level was around 4.11, and his serology was negative. And his immunofluorescence showed deposition of immunoglobulins with IgG being stained as 2+, IgA 1+, IgM, kappa and lambda being 1+, in the mesangium with slight amount of deposition of IgG in the GBM as well. So it was reported as a mesangiocapillary glomerulonephritis with FSGS. The C4D was positive significantly without any evidence of active rejection, but a possibility of transplant glomerulopathy which needed to be ruled out was reported. If we look at the BAMF scores, the acute BAMF scores, except for C4D being 2+, all were mainly negative. The chronic BAMF scores, CG was significantly positive, being CG3, and at this point of time, his baseline immunosuppression was mainly hyped up. The dose of tacrolimus was increased, and the patient was introduced on antiproteinurics. Like in this case, he was introduced on ACE inhibitors. Ramipril was started. So with this, there was gradual reduction in the proteinuria and the serum creatinine remained stable. But at the mid of 2022, however, there was again worsening in the proteinuria, which went up to around 4.6 grams per day. And at that point of time, he was advised or planned for a hike up in the immunosuppression by taking him on anti-rejection therapy. He was actually enlisted for a trial which was going on at that point of time. It was being conducted with, however, during the screening, the patient was found to be IGRA positive, and due to that, the therapy was deferred and the patient was started on INH prophylaxis. And at that particular time, as because we deferred the therapy, he was advised to undergo a rebiopsy. So the rebiopsy, however, significant double contouring, prominent double contouring was seen all throughout in the glomeruli. However, any kind of evidence of microvascular inflammation like glomerulitis or PTC was absent. And there was also absence of any kind of significant interstitial inflammatory infiltrates. The JMS stain sample also here showed a prominent double contouring. But this time, in the evaluation, the albumin was slightly low. That was 3.1. There was no presence of any active sediments. The complement levels were again well preserved. The whole blood, the E0 level was around 5.7, which was well within our norms. So when we looked at the immunofluorescence, however, this time the immunofluorescence was completely negative. The C4D was also completely negative. Only the positive finding was prominent CG, that was scored as CG3. So it was reported as transplant glomerulopathy. So further anti-rejection therapies were deferred and the patient was continued on maximal antiproteinuric therapy. The patient was actually started on telmisartan at this point of time, and the target for T0 was kept to be more than 5. The triple standard immunosuppression therapies were continued. Over the next few months, there was again reduction in the proteinuria. However, by end of 2023, it started to go up again. And by late 2023, it actually peaked up to around 7.9 grams per day. So the patient was again, the dose of prednisolone was increased and he was started on 1 mg per kg per day prednisolone. However, within a few weeks, he developed lower limb cellulitis, which was again managed with oral antibiotics, but the prednisolone was rapidly tapered out to balance out the net immunosuppression, as the T0 level was around 7.71 with only 1 mg twice a day dose. The tacrolimus was continued with that, and the prednisolone was tapered to the baseline level of 5 mg per day within a period of 8 weeks. However, we actually increased the dose of telmisartan to supraphysiological levels to counter the proteinuria. But even despite that, there was marginal reduction in the proteinuria, but all throughout 2024, there was progressive worsening of the proteinuria as well as the renal function. The serum creatinine levels went up gradually and at present continue. They stand at 2.8 mg per deciliter serum creatinine and the proteinuria, 24-hour urinary protein at 9.2 grams per day. So if we look at the overall course, the initial biopsy, which was suggestive of transplant glomerulopathy, probably secondary to a chronic antibody-mediated rejection. But in the initial biopsy, because of the presence of immune complexes, we can keep a possibility of immune complex mediated MPGN recurrence. That remains there. And despite the initial stability of serum creatinine, now, however, we see the progressive worsening of the gut function despite optimal immune suppression as well as antiproteinuric therapy in the form of worsening proteinuria as well as increasing serum creatinine. So the main two components here, that is the transplant glomerulopathy and maybe a recurrence of an immune complex mediated MPGN, which stay there. And if we look at the immune complex mediated MPGNs, usually it can be due to polyclonal antibodies or monoclonal antibodies, and higher recurrences is noted with monoclonal antibodies up to 60 to 65%, which usually occur early and cause increased amount of graft loss. Polyclonal are a bit more benign, occur late, and the graft loss percentage of graft loss is much less. The occurrence of MPGN in young age with heavy proteinuria or a crescentic primary disease or history of prior graft loss or documented C3 recurrence of C3GN or a monoclonal gammopathy increases the possibility of graft loss in this. Transplant glomerulopathy, by definition, is the duplication of GBM and in the absence of de novo or recurrent glomerular disease or any evidence of non-rejection associated TMAs. And it reflects continuous injury to the endothelial cells because of various means. Most commonly, the mediator is chronic alloantibodies or the donor-specific antibodies. And a diagnosis of transplant glomerulopathy or a histological finding of transplant glomerulopathy actually bears adverse implications towards the graft survival. And the studies which have looked into the recurrence of MPGN have actually shown the disease recurrences occur in around 25% of the cases, and about 37% of cases there are graft loss, the main prediction for concurrent development of rejection, as well as in patients who have dysproteinemia and complement mediated MPGN have higher and whenever there is the recurrence time is early recurrence from post-transplant period with low EGFR at the point of time of diagnosis, as well as serum albumin less than 3 gram per deciliter during the time of diagnosis, actually all bear adverse implication for the graft survival. The transplant glomerulopathy being a common pathway or the end point of multiple pathways of injury to the endothelial cells mediated by either antibodies, HLA or non-HLA antibodies, or by non-humoral pathways like T cells, NK cells, and macrophages, or by other infections like CMV and hepatitis C, or other mediators like drugs, which all result in endothelial injury as well as podocyte stress, which translates into the development of transplant glomerulopathy. So in our case, mainly there are multiple issues as well as lacunae that even if there was an initial C4D positivity and deposition in the immunofluorescence, it was not found in the subsequent study. And despite initial stability, there was a rapid worsening of the renal loss in the last 1 year, as well as renal function in the last 1 year, as well as the proteinuria has increased significantly. And even if there is a possibility of chronic AMR, the other evidences which might have highlighted an antibody-mediated rejection like microvascular inflammation were completely absent. Our main lacunae here is that we don't, as because the patient's entire course was during the COVID period and the patient had severe financial constraints, we don't have the electron microscopy available to look at the ultrastructure for the deposition of immune complexes. Neither we could do a DSA studies to identify any possibility of antibodies in the body. Neither we have the biopsy proven diagnosis of the native kidney disease, which could have given the possibility of an MPGN being the NKD. With this, I would like to conclude my presentation and go further with the discussion regarding the case. Thank you.
Thank you, Dr. Aniruddha, for this insightful presentation. So now, my privilege would be there to moderate the question answer session with our Honorable President, Dr. Arpita Madam. So, Madam, from your end, what question would be there for this?
Yeah, thank you, Dr. Shrimali, for giving me the opportunity. So, Aniruddha, my first question would be, what do you know about his native kidney disease? We have a specific pattern of MPGN, usually immune complex mediated MPGN that we see in adulthood. This boy, if I remember correctly, is full grown. It doesn't have a history of childhood nephrotic or nephritic syndrome, doesn't have a history of childhood CKD. He is 6 feet tall, good health, and good BMI. So what was in your opinion, what was his NKD? What do you mean by CGN?
So, madam, most commonly most commonly what this patient actually came to us when he was already in a chronic kidney disease stage 5. His previous urine reports which were available showed amount of proteinuria which was somewhere around 2 plus, and he had few RBCs present. He had a baseline history of being hypertensive, but the duration was not known. We did not know anything in the past, but due to his uh, growth of his body and everything, we can understand the stigmata will not be of a childhood onset. And most commonly in our population, IgA nephropathy has a tendency to present like this, present whenever they are almost reaching the ESRD stage. So with this background, we had thought his possible native kidney disease probably would be a IgA nephropathy.
Okay. So this finding that you find and the history of the disease after recurrence, it's some spontaneous remission with some antiproteinurics, and then again going to very high proteinuria. Does adult MPGN also follow this natural history? So that you can propose that this is a recurrence of MPGN, or this severe proteinuria reminds you of some COVID-related MPGN. Because if you remember, after 4 years of quiescence, this patient presented in COVID period with subnephrotic proteinuria and active sediment in urine, which progressed to nephrotic range proteinuria with MPGN in biopsy. Do you want to keep COVID-related MPGN also in differential?
I would like to keep that in the differential also, ma'am, because the period of time, that time COVID was rampant. At that point of time, when his biopsy was done, he had deposition of few immune complexes. And after the initial treatment with antiproteinurics, he showed fair amount of response. His proteinuria was coming down, his creatinine didn't go up. Obviously, second time, when again it's spiked up, maybe something else was coming in, but that initial point of presentation maybe because of a infection or a COVID-related MPGN could have triggered.
This constant normalcy of C3, does that, so it might be a COVID-related PIGN as well. So its constancy of C3, does it suggest something to you?
In immune complex mediated, means this might not be, because it might not be a complement triggered pathway. If infection related this infection related MPGNs come in, it's not always that we get to see a hypocomplementemia associated with this.
Clinically, the course is not suggestive of an HUS C3 MPGN, C3GN recurrence. Clinically, it's more like an immune complex MPGN recurrence, which appeared late and is progressing slowly. So with these clinical perspectives in mind, particularly a COVID-related trigger of PIGN with immune complex MPGN setting again, I would like to take the opinion of our pathologist, uh, and our pathologist was one pathologist was Kea from IPGMER, but second biopsy is with our very, very revered pathologist, Anila, who has been really master figure in renal histopathology. I would like to take opinion of Anila in splitting the clinico-pathological correlation.
Dr. Arpita, thank you so much for those very kind words. There was absolutely no need to say all that. And thank you, Dr. Radhika and the entire team for inviting me. I have my major query is, see, Dr. Aniruddha, in your presentation, the first biopsy did not have any C3 deposits. So how could you call it as an MPGN without C3? You only said there's some faint IgG, some faint IgA, some C1q, but zero C3. For the definition of MPGN, you need to have C3. So I have not seen the first biopsy, so I'm just assuming based on the findings that you've given, there's always, if the IF can be sometimes tricky, There could be non-specific, deposition, especially if it's not been washed. And IgG, we know, gives a lot of background staining. So whether it was an artifactual IgG is what, after seeing the biopsy pictures and, C3 not being there, to call something as MPGN is little, out of the...
Difficult.
So, yeah, so probably that explains his complement level and everything. And he had an initial C4D positive. It could have been subclinical. You can just have C4D without microvascular inflammation. That is why overt rejection. It was subclinical. And it's characteristically, we know that multiple sub-episodic, subclinical episodes can cause irreversible or repeated endothelial damage, and then over time you start getting double contours as a part of healing. So if you just put aside those IF findings, then I feel you have a straight case of a antibody mediated rejection, which was indolent, subclinical, and then it never had a very catastrophic appearance. Over time, gradually, it has progressed to transplant glomerulopathy, and now he's having all the, overt symptoms of that. This, I mean, without seeing, I shouldn't be saying, but based on the description,
Probably would fit the course, ma'am.
yeah, that is what possibly, because IF can...
We don't have the DSA, we don't have the DSA levels, we don't have the electron microscopy, whether actually the immune complexes were there or not, whether they are...
Without C3, that's the main thing. Dr.
without C3.
You want to add something? Anything more?
Yeah, that I was asking Anila, that constancy of C3, that is also not a very common picture of MPGN. And the typical clinical picture of remission and recurrence of proteinuria in adult MPGN, that was also missing in this boy in his pre-transplant history. That was also not present.
Yeah. Any further questions?
What about what in your second biopsy, Anila, in what you have got in IF, in view of that, then C4D completely disappeared, and IF is...
Disappear. C4D can disappear. It needn't be that C4D has to be continuously there. The damage has already been done and it's irreversible. Now probably he doesn't have any complement deposition happening there in the microvasculature. That is quite possible. IF is completely negative. So when you have this picture of a MPGN pattern, like that is like that lobular accentuation and mainly double contours in a graft biopsy, the moment we see that on light microscopy, our first thing is to look at IF. Now, if IF is completely negative, then you rule out either a recurrent or a de novo GN. Then the two differentials are whether it's a transplant glomerulopathy or a chronic TMA. Chronic TMA, and these are, on the biopsy, we cannot differentiate it many a time. You will have to go by clinical parameters. Or if EM also shows peritubular capillary multilayering, then you go more in favor of a chronic antibody-mediated rejection against a chronic TMA. But chronic TMA ruling out is a clinical thing, which on the biopsy we cannot. So these are the two differentials I would put forth after seeing the second biopsy. But if other than that, with negative immune complex, we cannot think of either recurrent or de novo, any sort of a glomerular pathology.
Yeah. So about the, I was also interested because many times we had no COVID history positive, but a biopsy showing high grade, a clinical picture showing subnephrotic to nephrotic proteinuria in the COVID period, and COVID related PIGN like picture. Do you think that has any resemblance to it, though typical PIGN is also missing in this biopsy?
No, Dr. Arpita, without C3 to call it PIGN or MPGN.
Also, yes, I agree. The absence of C3 takes out the possibility of PIGN or MPGN.
Your serum levels may be normal, but the IF should definitely show for us to call it as a glomerular disease because of that.
Ma'am, I would
Yes.
like to add C4D was negative, right, in the second biopsy.
Second biopsy, C4D was negative.
So if it would have been recurrence of MPG and C4D would have been positive, like as it is a marker for a classical pathway activation.
Correct.
So that is also ruled out.
Yeah.
As you said, the other two differentials we should think of. Yes, ma'am.
So should we look at the chat box that whether any question is posted there?
Yet, I think there are no chatbot question, but
No, two questions are there, sir. You can take
yes,
that.
yes.
Maybe.
Madam,
Acha, you go ahead, sir. Sorry.
so, okay, ma'am. So looking back, would you consider alternative induction strategy given for this patient, considering the aggressive glomerular disease and as well as later on more consideration for transplant glomerulopathy?
So actually, during our induction, in the induction therapy, we actually don't base on the per se the native kidney disease. Apart from maybe complement mediated disease may have a role of eculizumab particularly, but in our center, we mainly base it on the degree of sensitization the patient has or the patient's pre-existing history and the type of the donor. So our usual protocol is for related donors, haplomatched donors, like here the father was the donor. We usually go with induction with basiliximab and methylprednisolone only. We don't base it on the type of native kidney disease they might have. And his previous native kidney disease history was not that well elucidated. Only the presentation was in a very advanced stage. We drew back the conclusion from the urinary findings and the age and the presence of hypertension and everything, and probably a glomerulonephritis like IgA nephropathy may be the.
So that's the reason because we were not able to find out the exact etiopathogenesis for that glomerular disease. So in that case, sometime rather than basiliximab, ATG could be more useful. What's your view on that?
So ATG, so we can use, but again, because of there was not much of history of sensitization and it was a haplomatched kidney, we kept it on basiliximab, just on the basis of the protocol we follow. That ATG is reserved for unrelated donors or cadaveric donors.
Actually, Dr. Shrimali, in our institute, in IPGMER, we had a protocol of using induction on basis of sensitization history. We went for higher immunosuppression with sensitized patients because in a public sector patient, going for higher induction always induces a risk for infection as well. The patients go back to an environment where infections may be rampant. So we become a little restrictive in using ATG in all patients.
Okay.
Similarly, we didn't ask for a DSA without any history of, he had a history of single blood transfusion, no other sensitization history. So we usually don't go for a higher immunosuppression.
Okay.
So, yeah.
Yes. So, Dr. Aniruddha, how do you approach long-term management in this patient with transplant glomerulopathy? So, do you believe that there is a role of any newer agent or rituximab in this case, and how you will approach for over versus under immunosuppression?
So, so the role of rituximab in transplant glomerulopathy is a bit dubious, especially if we have a presence of very early onset transplant glomerulopathy, maybe within the first 3 months of or immediate post-transplant. In that period, if we get some kind of evidence like this, then maybe rituximab may be in the part of the protocol for treating it. Usually, when we are treating a case of transplant glomerulopathy, we think about a antibody-mediated rejection, and primarily we restrict ourselves to plasmapheresis and IVIGs. The rituximab's role has not been very well established in this. It has not given as good as result as it is a part of a desensitization therapy when we use it for desensitization. But looking on a long-term goal or a patient who has this period, who is around 7 years from his transplant now. So in this case, my overlook would be to mainly optimize the other parameters. Like we would like to go for weight reduction, sodium restriction, as well as blood pressure control, ensure that he's not developing diabetes, and maximizing the role of other non-immunosuppressive therapies like antiproteinurics to reduce the proteinuria. And then we would try to keep the baseline immune suppression on a hiked up level to ensure that his net immunosuppression is well controlled. And this over immunosuppression and under immunosuppression, we would like to balance out by other clinical features, like we would like to follow the T0 levels, and we would like to see for any evidence of other concurrent infection, or whether he is getting recurrent episodes of concurrent infection like skin infection or recurrent respiratory tract or fungal infections, everything. We would like to balance it out on that.
I think the patient was once Enigma positive and again had cellulitis episode once.
Yes, that was.
With this consideration, what tacro level you would like to maintain otherwise, and considering again the creatinine value remained over the higher end and was progressive over the time. So with this again, CNI toxicity was also the concern. So in that situation, what T0 level you would like to follow?
So I would like to keep it somewhere around 5, not going below 5, somewhere around 5 to 5.5 maybe. Not going too higher up on the scale. The patient actually had a higher up level when he presented with this cellulitis. He had a level of 7.79. So we had to bring the tacrolimus doses a bit down because we had hyped up the prednisolone, thinking that probably a podocytopathy might be involved because his proteinuria had spiked up to 9 grams. So the prednisolone was empirically increased. So at that time, to balance it out, we reduced the tacrolimus.
Okay. So Radhika madam and Anila madam, from your side.
Yes, sir. Madam, it's privilege to learn from you always. Anila ma'am, what is the typical time frame for the development of early transplant glomerulopathy post-transplant, madam? Like,
see, if we do EM on every case, then we'll be able to pick it up within a few months. 2 to 3 months is what they say. But we are not doing EM on every case. So probably within the first year, it is not very common. 1 year after, you can, quite often we see some amount of transplant glomerulopathy. The thing about TG is, it is not the percentage of the number of glomeruli that are involved when we score it. It is, you try to find out one glomerulus which has it and then try the one with the maximum. So you have to actually diligently look for TG. If you really don't look for double contours throughout, because it can be very patchy. Unlike a primary MPGN where you'll have double contours everywhere, in transplant glomerulopathy, out of 10, only 1 or 2 may show in the early stage. So it all depends on how much the pathologist is running after it to look for it to find it.
yes,
So
ma'am.
in the early stages. So
Yes.
that's it. But otherwise, EM, yes, within 3 months you can pick it up. The 1A lesion. CG1.
Radhika, I
Yes,
have
ma'am.
one question for Anila.
Yes, ma'am.
Anila, the MVI, the microvascular inflammation, has been given immense importance in diagnosis of ABMR in your recent. What is your take on this MVI issue?
No, Dr. This MVI is now just a new frame. What is MVI? MVI is actually glomerulitis and peritubular
PTCItis.
pancreatitis. The same thing. It has just been given a new package, new name. Earlier, we used to call the G lesion and the PTC.
PTC.
So now it's the same thing, and you score it like 1, 2, 3, like how earlier it was. Same way, both of them. And then now the MVI score is you add these 2 scores. And anything more than 2 is like considered significant. So
Yes.
that's all that means. It's like old wine in a new bottle. It's the same thing.
Yeah, that I understand. Though the G plus PTC is 0 plus, but you are proposing for ABMR. Then what would be your what are the signatures for those that suggestion?
If G and plus PTC is 0,
as it happened in this case,
like in that case, there is no acute component. There's no active component, not acute. Now we don't use the term acute antibody. It is active antibody mediated. There is no active component. So we have those 3 criteria. Like if the C4D is still positive and your DSA is positive, then it is okay. But if your C4D is negative, MVI is also negative, then you don't consider it as an active. So you have to have the 3 parameters ideally.
Yes.
The MVI 0, you have to really be very convincingly positive. The other features should be there to even consider antibody.
So clinically, that is the reason why we were little hesitant to consider ABMR in the first go and put him on anti-rejection therapy when his creatinine rise was very modest. Aniruddha has showed that creatinine rise was not that big. Only there was urinary abnormality without much rise of creatinine, and G plus PTC was 0. We didn't have a baseline DSA at hand because considering father and son, the related donors, we didn't go for really blood group match, and there was haplo match. We didn't go for exploring DSA. So initial DSA was not in our hand, and we couldn't repeat DSA at that moment as well.
Also, Dr. Arpita, you can have a transplant glomerulopathy with just subclinical episodes of antibody-mediated rejection. You don't have to have overt ABMR for it to become a TG. Just even there are, multiple cases where even protocol biopsies picks up TG lesion, but the patient is absolutely normal. So we should probably in this person consider that he's been having subclinical rejection antibody.
There was proposition in one of Jordan's article, S.C. Jordan's article, that there is a subclinical TCMR and then it progresses to chronic ABMR without any overt active ABMR. So in this biopsy, we didn't have that much interstitial inflammation as well. So that subclinical TCMR triggered chronic ABMR. That is also a probability which may happen.
Yes. Ma'am, one question from the chat box. How biopsy could guide in taking treatment decisions in TG, active versus inactive ABMR, IFTA? Maybe Arpita.
How taking treatment decisions?
Arpita
can answer that?
Yes. Yes. Yeah. So in when I find that there is that clinical history is very, very important. If it comes within 1 year and it's a C4D positive transplant glomerulopathy and C4D positive active ABMR, what Anila was referring to, G plus PTC is positive, whether there is TG or not TG. Anila was telling that it is likely that there is a patchy TG which might be missed without a very close vision. G plus PTC or DSA plus C4D, G plus PTC with C4D, any 2 of the 3 criteria, when present within 1 year, I usually go for plasmapheresis because there is a pattern that early ABMR, usually the anti-DSAs respond to plasmapheresis. So plasmapheresis followed by IVIG. Sometimes we have given rituximab and in some cases bortezomib without any long-term gain, but with increased risk of sepsis. So in IPGMER protocol, we had ultimately dropped rituximab or bortezomib, and we had gone for plasmapheresis and IVIG, high-dose IVIG for this early ABMR. And for late ABMR happening 4-5 years down line, we usually exclude plasmapheresis and we had given only IVIG, and always in both cases along with hiking of the baseline immunosuppression. What we have done recently, a small tocilizumab trial, in a retrospect, we compared it with the retrospective cohort and made a prospective cohort of chronic ABMR treated with monthly tocilizumab up to 2 years. And we found in patients who had been given on standard of care plus tocilizumab, they had less infection, relatively stabilized chronic ABMR, less progression to the graft loss compared to the retrospective cohort from 2017 to 22, where we didn't give tocilizumab. Only the SOC was plasmapheresis plus IVIG for early, and for late only IVIG, or sometimes with retux plus IVIG. So comparison of these two groups had shown some benefit in terms of tocilizumab, which had been we had taken this presentation to ISOT and also to TTS, and still not it has been published or written, but we are thinking that we would publish. Only limitation with it is we had compared a prospective cohort with a retrospective cohort. We do small number, we are not a very high volume center, so we cannot recruit simultaneously in SOC plus tocilizumab. We have compared with our retrospective and prospective cohort. But we have definitely at less risk of infection and stabilization of graft function. Radhika.
Yes, ma'am. Dr. Sudeep asked, what is the dose of ATG you use in case of induction?
I think Aniruddha will be taking this question.
We use standard. During induction, we use 3 mg per kg. The total dose, we divide it on 3 days. On day 1, 1 mg, day 2, 1 mg, and day 3, 1 mg. As for that, we give a total of 3 mg per kg for the induction.
We keep on monitoring after the dose whether the patient does develop thrombocytopenia.
Leukopenia or thrombocytopenia, we modify, and according to that, we can modify.
Yeah.
Total cumulative dose is that.
Thank
So
you.
in any case, patient has had a previous history of recurrent infection, and if you are planning for ATG, in that case, you do any change in the total dose from the start, or the leukopenia would be the only criteria?
So we take the induction as it is. We only modify it according to leukopenia. If the patient has pre-existing history of any other illness or something, then we again try to modify. And if he's a high-risk case or something, but still usually we follow the norm of 3 mg, because below that dose might be a little sub. We are a bit afraid that it might be a bit subtherapeutic. Treat as an induction, going below 1 mg. Going below total of 1 mg per kg. Sometimes in few patients we had given 0.5, that is 1.5 mg per kg, but that so far it has been so good, but it's not. It has not been compared. These two doses we have not compared actually the outcomes, how they are doing.
Arpita madam, your experience with the dosage of 1.5 to 2 mg per kg for the ATG, otherwise, because many centers are still with infection, they are using the lower dosage.
We are using quite low dose, 3 mg per kg, total dose, divided in 3 doses. And sometimes when the thrombocytopenia or other contraindications come in, we come down to 2 mg dose. I have no experience of using even lower dose, but with history of recurrent infection, we have used we have used basiliximab instead of ATG. But ATG with much lower dose, I haven't used much.
Okay. I think the
Do you
question
have,
from
Dr. Shrimali, your experience, you
Yes,
have used?
madam, what we are doing routinely is 2 mg per kg.
Okay.
We very rarely use 3 mg per kg. And
You are happy with
otherwise,
2
as far
mg
as
per kg dose?
yes, madam, over a
Okay.
span of once or twice we had antibody mediated rejection till date otherwise with this.
Okay. Okay.
The question from Dr. Sanjay Kumar Agarwal. Please comment on the chronic active versus inactive antibody mediated rejection in this case?
Yes. Anila, ma'am.
Yeah. So this, I mean, there is by BANF, there is nothing like inactive, but since C4D is not present and since there is no microvascular inflammation, we should consider that this is not an active antibody-mediated rejection, this particular case.
And for treatment aspect, Anila, somebody was asking inactive. I was talking about active there. So inactive, I forgot to take up. I am coming out that we can extend the supportive care. Here, antiproteinuric management is very important because proteinuria is directly related to the faster progression of faster progression to ESRD. So our antiproteinuric armamentarium recently had been enriched with SGLT2I and finerenone. And even after that, sparsentan, though sparsentan is not available with us. All these newer drugs are experimentally being used in post-transplant patients with proteinuria. I think they didn't have, till now, they haven't come up with a certificate of a guideline, but we have started using them off-label. For Rajiv, I was using finerenone. I was little anxious to use SGLT2I if it precipitates a genitourinary infection or so, but I started using finerenone when I couldn't get down with proteinuria with supraphysiological doses of ARB. When I used finerenone, he probably had gone little high up in potassium, about more than 5.5. And then sometimes I practice the use of chlorthalidone as diuretic as well as control of BP measure, very good BP controlling, long-term BP controlling with a single dose, and it causes slight lower hypokalemia, potassium excretion. So with a combination of telmisartan, chlorthalidone and finerenone, probably some more reduction of proteinuria can be targeted.
I think the question is from Dr. Rakesh Chauhan. May we have a protocol to native kidney biopsy always to have a baseline information for future correlation?
Yes, sometimes doing native kidney biopsy in late stage would give you only some glomerulosclerosis without any idea of native kidney disease. Sometimes we even go for doing that, and if we get IgA in IF, we get the hint that this is an IgN. But otherwise, you can get only, and risk of bleeding and everything is much more. It may even complicate the course. We do give dialysis and then use other measures to reduce bleeding, but not always.
Okay. So,
One more question is there, sir?
I think, is there any question, madam?
Yes, sir. One more question is there. Dr. Sudeep sir asked, he
Okay.
has just received a patient of chronic ABMR, but no C4D. How does we explain that?
Anila.
Yeah, okay. I was like,
Sorry.
see, two things, chronic active antibody mediated rejection, chronic, what was it? What is a TG score? What is a CG? What was PTC? Can you specify more on that on the report, Dr. Sudeep? Or another way I can put is C4D, it depends on what method you've used. Is it immunofluorescence or immunohistochemistry? Immunofluorescence is much more sensitive. So it's possible that the immunohistochemistry, if you've done, which is more commonly being done, may not have picked it up. That is one. Second, it could be a patchy positivity. So we need to know a little bit more details on how you called it a chronic antibody-mediated rejection. What was the full report? Was there glomerulitis and peritubular capillaritis, or only chronic, only a CG lesion?
He has mentioned.
No, without that, You want to add something?
IF was used, he said, madam.
IF was used. IF was used and no C4D. So it should be something like this particular patient then. There is some chronic injury happening, but nothing active going on.
And whether previously it was documented as C4D positivity of active antibody mediated rejection, that should be there. So
definitely.
Yes, that, yes, okay. One, just he's, I think.
He's type.
CG3, madam, CG3, G1, PTC1. He's typing.
G3.
So together PTC, G plus PTC2.
Chronicity happening. And there is a MVI2. Yeah.
Earlier report.
Yeah, so I think no need to treat, right? Yes, I would say no need to treat. If everything is coming down, then probably you should not treat.
Yeah, it is also coming down.
Yes, this is what the pathologist.
Okay, you have already read. Okay, okay.
I leave it to the pathologist.
I think one more question. C4D is a foot mark. How long it will be there in a biopsy?
Yeah, it depends. For a few weeks, it will be there.
So, madam, for if any transplant glomerulopathy, if the patient require future retransplantation, then induction agent, maintenance immunosuppression, what further care we should take?
For me?
Yes, madam.
Yes. So I would go by the second transplant is highest form of sensitization. So I would never go, I would go for a sub with the proposed donor. If he waits in the cadaveric list, I will look for PRA and I will try to find out the unacceptable antigen. If I do have a really population background, that what are the common ones. So PRA and for cadaveric donor and for this like live donor, I would go for DSA. Depending on DSA, the DSA strength, the additive DSA, I would decide that whether the patient would require desensitization or I would just say that wait for a patient who wait on cadaver list, or it is very difficult sometimes with high MFI to find out a donor in cadaver list. So if it is a live donor, we can go for desensitization if the patient is too much willing for transplantation. So desensitization, more than 10,000 sub, I would not recommend for even desensitization based retransplant. But less than that, we may try desensitization. And if the DSA is not that high, we would go with ATG. And the desensitization protocol may need plasmapheresis rituximab addition.
May I just add to this? I mean, especially since you asked if this is going on for a next transplant, and you've seen only a CG lesion, you've only seen transplant glomerulopathy. See, for a pathologist, we assume it's more likely to be transplant glomerulopathy, but always keep in mind that chronic HUS can look exactly like that. So you need to work up for an atypical HUS. With this double contouring and no other features of active antibody mediated rejection before the patient goes for a second transplant.
Yes, right, Anila, right. I have forgotten to mention it. Even this patient, if wants retransplantation, remembering his first presentation. So his first presentation, as I can remember, was an accelerated hypertension, followed by sudden detection of 5.5 creatinine and shrunken kidneys. So chronic TMA was thought in our mind, but we didn't find any C3 low C3, or all HUS do not have low C3. So definitely with this history of ABMR, we should move into the genetic workup, and then only we will exclude HUS.
Yeah, Anila ma'am, I would like to ask, what is the importance of IF in post-transplant? Like, how often they should take the another core, or only LM core is fine if we are doing the C4D by immunohistochemistry?
So if you're doing C4D by immunohistochemistry and you're taking only one core, I would suggest that whenever you're suspecting, whenever there's proteinuria, definitely you have to take a second core. Any case of proteinuria, even 1+, because we see a lot of IgA, recurrence, and even de novo IgA with just 1+ proteinuria and massive 3+, 4+ intense IgA deposits. And many of these patients rapidly deteriorate. So any proteinuria, you have to do an IF. And second, if the native kidney disease is an MPGN or something, which has a high chance of recurrence, then definitely you should do a IF. I always get the nephrologist to take 2 core because we do C4D by IF, so we always have tissue, and that's a huge advantage. And 2 cores, as per BANF, you need 2 cores, right?
Yes.
So if you have a second core for IF, we can always reprocess it for light microscopy also. So
Yes.
if you can make a practice of taking 2 cores and sending one in Michel's and one in formalin, that would be ideal to cover a lot of conditions.
So this will help you to go up to EM whenever you like to.
Yes, we can go to EM. Everything is there. So just one additional core would be a huge benefit as compared to just taking one core. Or now if we have paraffin immunofluorescence. So even if you have one core on the paraffin block, we can do paraffin immunofluorescence as a salvage technique also.
Yes. Somebody asked, like, what is the easy way to learn BANF for exams?
That's a nice question.
Very good question. Very good question.
Unfortunately, even we have to Radhika.
I think every student will be happy to learn from Anila. Give the mnemonic key.
We don't have any mnemonic, and every 2 years BANF meets and complicates it.
Brushes up the previous one. The molecular signatures are brushed up.
Yeah.
Yes. Jigar sir, please take up the last question. Yes.
So, any particular desensitization protocol is there, are case-based when it gives Plex, rituximab, IVIG, on what basis it is planned?
Arpita madam.
Repeat the question, please. I became a little inattentive.
Yes. Any particular desensitization protocol is there, are case-based when to give Plex, rituximab, IVIG, on what basis it is planned?
Yes, usually there are several centers who practice desensitization, and they follow a protocol to keep watch that whether the protocol is at the end of some time frame is really giving benefit to the patient or not, what changes need to be done. So in whoever has asked this question, in your institute, you can take up a protocol. Usually first thing we do in early ABMR is plasmapheresis, and post plasmapheresis, you can give the, desensitization, not in the treatment of ABMR.
Yes, madam. Desensitization protocol.
Desensitization. Then it is rituximab, plasmapheresis, and rituximab again. And if you still have the DSAs high, you may need again plasmapheresis. Usually 5 to 7 sessions of plasmapheresis initially. Then you earlier have given rituximab, plasmapheresis, and then again you may go for a second dose of rituximab and plasmapheresis if needed again before doing the transplant, looking at the DSA.
Madam, with this plasmapheresis, will be there with IVIG or only plasmapheresis?
For desensitization, IVIG is not a must. The IVIG we use more in treating the ABMR protocol. Do you use a IVIG for desensitization in your center?
Madam, we use 5 to 10 gram IVIG if we require to have plasmapheresis for more than 5 sessions.
Okay. Okay.
We supplement it.
Okay.
What is the mechanism of paraffin immunofluorescence? Anila, madam.
I'll take that. See, what is why do we say that for IF we need to get a fresh tissue? Because what happens when you fix the tissue? When you're fixing the tissue or putting the tissue in formalin, you're having protein cross linkages, right? So the proteins get, they get hidden. So when you put the antibody, like you want to look for IgG, so you put anti-IgG antibodies, even though there is IgG there, this antibody that you're applying onto the tissue is not going to be able to go and bind to the antigen because of the cross linkages. That is the thing. That is why we say the IF tissue should never be put in formalin. It should not be fixed. It should be fresh tissue because fresh tissue, it is all open. So easily the antibody can go and bind to the antigen. Now, paraffin immunofluorescence is a mechanism where you do what is paraffin? Paraffin block. That is a formalin fixed paraffin embedded block that we use for routine light microscopy. So that is fixed. So there we have certain enzymes which can break these cross linkages like pronase or protease. You would have heard, pronase digestion or protease digestion. So those enzymes are going to break those cross linkages that were formed because of fixation. So once you break those cross linkages, then the antigen is exposed. So when you put an antibody, it will go and bind to it. So that is and then the same procedure. So basically you're just doing one additional step of unbreaking the bonds that were formed by fixation. So that is paraffin immunofluorescence. You should not consider this as the ideal method. There's a lot of, background stain. You may get a false negative staining. So it's usually used as a salvage technique, though some diseases are diagnosed based only on paraffin IF. So that's another session by itself. But by and large, that is what it is.
Okay.
Thank you.
Madam, any role of eculizumab in desensitization?
Any role of eculizumab in desensitization? No, I am not aware of. Eculizumab is, no, I am not aware of. If you consider the mechanism of action of eculizumab, it can be hardly used in desensitization. It can be used before transplanting an HUS patient as a treatment of the disease and to suppress the complement dysregulation already present there. But it should not be should not be coined as desensitization. We may need to use it before transplanting an HUS patient as form of treatment and suppressing the complement dysregulation, so that immediately post-transplant, we do have a recurrence.
So it is more for prevention of recurrence rather than for desensitization.
Yes, it is prevention of recurrence rather than desensitization.
Yeah.
I think we don't have any question with us. Radhika madam, from your side, or Anila madam, Radhika madam, any more question?
No.
No.
So as we come to the end to this engaging intel and stimulating webinar, it is my privilege to deliver vote of the thanks. On behalf of the team, I extend my heartfelt gratitude to our Honorable President, Dr. Arpita Madam, for the guidance and for sharing her valuable insight for the today's case. And special thank to Anila Madam for her presence and thought-provoking discussion that enrich today's case presentation. And thank you, Dr. Aniruddha, for the excellent presentation and for answering question and answer. So me and Dr. Radhika, thank you all of you. Thank you, madam.
Thank you.
Thank you, Jigar and Radhika, for taking all the pain of organizing the meeting and running the meeting so well. Thank you, Anila, for being with us.
Pleasure. Please.
Anila is a long-term pal for me.
Yes. Thank you, ma'am. Thank you, Anila ma'am. Thank you, Arpita madam. Thank you, Aniruddha sir.
Thank you all. Thank you all. Aniruddha, thank you for a nice presentation.
Yes.
It was an excellent.
It was nice presentation. Yes.
Okay.